Good evening, everyone. How are you all? Welcome to First Aid AMC Clinical free 2-week session cardiology class today. Now, again, I'm very sorry. There was a bit of messed up situation with the Zoom ID. So always remember that for my classes, this is the Zoom ID that we are going to use for this free 2-week session. For Dr. Cynthia's class, there will be a separate ID that we will provide on the Facebook group. Okay. So I think what I have done is that I just put Dr. Cynthia's class ID for today, and that's why it was a bit messed up. But I can see most of you are here, so it's not bad. So let's start our cardiology session today. And before we do, so you guys, many of you might be new in our session. So this is our free 2-week sessions that we always do for our new batch. So as you know that our new batch has started from 10th of March. So far, we have taken on 25th February, we have taken our psychiatry mental status exam theory class. Then on 10th of March, we took psychiatry MSc role play session. And then after that, yesterday, Dr. Cynthia took a random role play class. And today we are going to do a cardiology session. Right? So this is so far that we have covered in your free classes. And still we have few more things to go. So this is your first class on cardiology. Then there will be another class on cardiology followed by a random role play session. Then we will do a cardiology role play and we will also do a pediatric class. So that will cover our free 2-week session for this batch. Now, if you are not aware, this is already course classes. So these classes will not be repeated in the course. So basically, all of you are getting the free sessions, but this is actually a part of course as well. We take these classes just to show you how the course is going to be, how our classes are going to be like, so that you are fully aware of it. Okay. But you know that First Aid AMC Clinical has the highest number of passing candidate in AMC so far. Especially for AMC Clinical, there is no other course which has this much number of students who pass every month. Now, the reason behind it, obviously, how we guide our students, but also how much hardworking our students are. So both actually has equal amount of credit to go for something like that. Previously, there was a time it was very, very hard to pass the exam in the first attempt. But if you look in our group, you will see that most of our students who are passing the clinical exam, they are first-time candidate. So that's a really, really a good achievement, and we are really proud of that. Today, you are going to have a understanding about how our theory classes will look like. We always say about cluster-wise approach, so you will get an idea about what's this cluster-wise approach that we always say. Cluster-wise approach, it gives us an idea that if we can make your preparation concise, short, but also covering everything, that's what is cluster-wise approach. So we take one, let's say Syncope, that's your first cluster today. And under the Syncope cluster, we are going to cover at least 5 or 6 cases. And there are clusters which cover 10, 12 cases altogether. So this cluster-wise approach are smart way to pass the exam. And you will have a look at how we do it today. How did you like Dr. Cynthia's class yesterday? Did you guys, I know it is very, very hard to do a random role play if you're a beginner, but did you guys get along with her? Did you guys understand what she was talking about? And Dr. Bashir, no, that is not the all of psychiatry. For psychiatry, we still have 3 more classes to go. We just took 2 classes so far. And for cardiology, we will have 2 theory class and 1 role play class. Yes, so that was good. Perfect. Let's start our cardiology class then. So first of all, it is syncope. So syncope means sudden loss of consciousness. And what are the differential diagnoses for someone who has syncope? So syncope can be related to cardiovascular system, can be related to CNS, central nervous system, or even miscellaneous. But the serious is the important one. So syncope can be related to any kind of arrhythmia, could be aortic stenosis, HOCM, could be a myocardial infarction or prolonged QT syndrome. Exam cases are aortic stenosis. Myocardial infarction doesn't come under syncope, rather it comes under chest pain. Prolonged QT syndrome also sometimes can come in exam. CNS causes can be TIA or stroke, could be head injury, could be infection like meningitis, encephalitis, could be epilepsy. So stroke, infection, epilepsy, and head injury. This doesn't come in exam under CNS. Then others, vasovagal syncope comes in exam, very important. Postural hypotension comes in exam, super important for exam. Hypoglycemia can cause syncope, anemia can cause it. There are some medication which can cause low blood pressure or hypotension, and it can cause syncope. And sometimes it could be just psychogenic as well. So these are the main differential diagnoses for someone coming to us as syncope or sudden loss of consciousness. Now, in any kind of cluster-wise approach, first thing is learning the differential diagnosis. So you have to remember or memorize these differential diagnoses for exam also. When you get that 2-minute time to read a case, your first thing that you will remember is what are the differential diagnoses for this case. After that, let's go to the history of something like that. So syncope most of the time comes as an acute case. Anything which is very acute, in exam, you will always make sure that the patient is vitally stable before you start asking the patient any further question. So what are the vitals that we look for in a patient? There are 5 vitals that we look for. One is blood pressure, pulse, respiratory rate, temperature, and oxygen saturation. So blood pressure, pulse, temperature, oxygen saturation, and temperature. So these are our 5 vitals that we look for in any acute cases. Someone who is having headache for 6 years, that's not an acute case. But someone who just lost consciousness in the morning today, that's an acute case. Okay? So for acute cases, you are going to make sure the patient is vitally stable. So how will be our approach in this case? Now all of these are given in your platform. So in the portal, when you get the access, under theory note, you will see everything. So you don't need to write anything. Just listen what I am saying and how I am approaching these cases. That's important to know. So first of all, your 2 minutes is up, and then your 8-minute station will come up. So let's say this patient name is John. So you will say, "Hi John, this is Dr. Arshan. I'm one of the doctor in this hospital." Or if it is an emergency department, I'm a doctor in this emergency department. Very nice to meet you. John, from the note, I can see that you lost your consciousness in the morning today. I'm very sorry to know that. It must be very stressful for you. How are you feeling now? John says, "Yes, doc, I'm okay now." You say, "Very good." John, because you had a loss of consciousness today, before I ask you any more questions, first of all, I will make sure that your vitals are stable enough so that you can answer my questions. Is that okay with you? Yes, doctor. So because this is an online exam format, you can't ask the vitals from the examiner anymore, like you can in a face-to-face exam. So for online exam, you will just say to the patient that you are going to check his vitals, and then you will move on to the next question. So you have said that I'm going to check your vitals before I ask you any further question. Is that okay with you? Yes, doctor. Well, John, can you tell me exactly what happened today? Always start with an open-ended question in the exam, because with open-ended question, they will be able to give you any information that they are supposed to give it to you. Okay, so just make sure that if you start a particular station, always ask, can you tell me a little bit more about what exactly happened today? So when you say that, patient will give you a lot of information that I was climbing, maybe I was climbing the hill, or I went out for a jogging and suddenly I collapsed. So whatever information patient will give you, you will not ask it further. That's very important. A lot of students, what they do, that the role player has given the information, but they are asking the same thing again and again. So don't do that. If a information is given already to you, like patient already said to you that I was jogging and then suddenly I collapsed. So you will not ask this question. So what were you doing at that time? So that means you didn't listen to what role player has said to you. And that is a very bad thing in the exam. So we say that whatever hasn't been given by the role player to you, you will ask those questions directly. So let's say the role player did not say what he was doing at that time. Then you will ask, what were you doing at that time? Is it for the first time? If a patient said no, it is not the first time, you will need to ask a little bit more. So how many times this happened so far? Can you give me a bit of idea about previous episodes? So you need to know that is there any particular situation, any particular time patient is having these episodes. So get a very good idea about the past episodes as well. And then ask that, did you fall suddenly or did you feel any lightheadedness or dizziness before you fall? Now, if a patient feels that they are going to fall, that means there is a prodromal symptom before syncope. We say that cardiac syncope happens suddenly without any prodromal features. But if it is a vasovagal syncope or other syncope, many times patient know that he or she is going to fall. So there is a prodromal symptom before they actually collapse. So ask this question, did you fall suddenly? Or did you feel any lightheadedness or dizziness before you fall? Any headache, any blurring of vision, any weakness, any part of the body. So we are also asking about CNS. That means the nervous system related questions over here. So headache, blurry vision, weakness will cover TIA or stroke. Okay. Now any kind of syncope cluster, we divide the syncope questions to pre-syncope. That means what happened before you lost consciousness, what happened during syncope, and what happened after syncope. So always divide it into three parts like this. So before syncope, was there any symptoms or did you just fall suddenly? Did you have any headache, any blurry vision, any weakness anywhere in the body? Then for syncope, was there any weakness with you? Because when patients lose consciousness, they will not know what actually happened. So if someone was there with him, then they can also give us very good information. So was there anyone else with you at that time? If yes, then you can always say that if you give me the consent, I would like to ask a little bit more about what happened when you lost consciousness. So you can always say that you want to ask the witness that what exactly happened after you lost consciousness. If there is no witness, then you can say that, did you lose consciousness? How long? Did you have any jerking movement of the body to rule out epilepsy? Did you wet yourself or pass stool? Same epilepsy. Did you bite your tongue? Did you injure your head? So we want to know that, did you lose your consciousness completely? If yes, how long were you unconscious? And was there any sign of epilepsy, like any jerking movement? Did you soil yourself? Did you wet yourself? Did you bite your tongue? Any of those. And did you injure your head? Because when a patient falls suddenly, they can hit the head. And that's very important thing to rule out. After syncope, then we go to the post-syncope question. After you gained your consciousness, were you able to stand by yourself or someone helped you? Why? Because if a patient able to stand immediately after gaining consciousness, it means that syncope happened suddenly and regain or gaining the consciousness also happened quite suddenly. So these kind of features are more goes with cardiac syncope, where syncope happens suddenly. That means patient will collapse very suddenly without any prodromal symptom, and they will gain consciousness also very suddenly. And there will be no confusion or drowsiness after that. Ask the patient, did you feel confused or drowsy? If yes, how long were you drowsy? Because if it was an epileptic patient, they will at least have a confusion or drowsiness for 30 minutes. And then after you regain consciousness, did you have any weakness anywhere in the body, any problem with your vision or speech? Okay, so that's your pre-syncope, syncope, and post-syncope questions that you will need to ask. Okay, so far you know that what are the questions that we are going to ask before syncope, what are the questions we are going to ask during syncope and after syncope. Once you have done your syncope questions, then you will move on to the differential diagnosis question one by one. So we know that we have CVS questions. So for CVS, only question we are going to ask that, do you have any chest pain, any shortness of breath, any racing of your heart? So chest pain, shortness of breath will cover myocardial infarction or ischemic heart disease. And for arrhythmia, you can ask about racing of heart. For CNS, we already asked a lot of CNS questions. So we ruled out TIA and stroke by asking weakness, blurry vision, problem with speech, right? Only thing we could ask, any head injury, and we can ask about infection. So any fever, any rash, or any neck stiffness. So if you go back, you can see that we have already asked all the questions. Like for arrhythmia, racing of heart. For aortic stenosis, it has a triad of chest pain or chest tightness, plus shortness of breath on exertion, plus syncope. So say we have asked chest pain, shortness of breath. For hook'em, same, shortness of breath and syncope. MI, we are asking. Same for prolonged QT syndrome, there is nothing you can ask. For TIA or stroke, you have asked about weakness, vision, or speech problem. Head injury, you are asking, you have asked epilepsy question, and infection question, you are asking about fever, rash, neck stiffness. So CVS and CNS is done. Then you are going for some of the miscellaneous differential diagnosis. So you have got hypoglycemia. So you can ask the patient, did you skip your meal today? So many times, hypoglycemia can be like patient did not have any breakfast and then suddenly went for a very vigorous activity, like went to the gym, and then their blood sugar fall down and they could get hypoglycemic attack. So did you skip your meal today by any chance? For vasovagal syncope, there is not much of a question that you can ask, but the understanding about vasovagal syncope is that if a patient stand for a long time, especially in a hot, sunny weather, sometimes when they do that, there might be peripheral pooling of blood because of vasodilation. So because of peripheral vasodilation, sometimes there will be pooling of all the bloods into the extremities. So if the bloods are mainly to the extremities, then there will be lack of blood supply to the brain and they can get syncopal attack. So you can ask the patient that, like, were you in a very hot sunny weather, okay, or were you doing any excessive exertional activities today, or were you standing for a long time before this happened? So any of these questions are fine. So if the patient says that I lost my consciousness 2 days ago, and then you can ask, well, was it a very hot sunny day? Were you doing any excessive exertional activities under the sun? Were you standing for a long time before this happened? So all of this will go with the vasovagal syncope questions. For postural hypotension means when they change their position from, let's say, lying to sitting or from sitting to standing, there might be a sudden change in blood pressure. So someone, when they get up in the morning, suddenly they feel very dizzy or sometimes even lose consciousness. So when they get up in the morning from the bed, they are changing position, right? So when they change position, if they feel dizzy, it's likely to be postural hypotension. So you can ask the patient, do you feel dizzy or lightheaded when you get up from the bed in the morning? For anemia, you can ask, do you feel very tired and fatigued these days? And then you can ask about any stress at your work or at your home to rule out any psychogenic cause. And lastly, finish with past medical history, SADMA, and family history. So for past medical history, how is your general health? Any medical condition like diabetes, high blood pressure, or any other known heart condition? Do you smoke or drink alcohol? Do you take any regular medication? Any family history of heart disease? Any family history of sudden death due to heart condition? There is two conditions where you can get sudden cardiac death in the family. One, HOCM, which is hypertrophic obstructive cardiomyopathy, and another is prolonged QT syndrome. So history of sudden cardiac death is also very important in this cluster. All right. So this is your format for this case. If we give a summary of this. So first you introduce with the patient, reassure the patient, make sure patient is vitally stable, and then you ask an open-ended question. So ask the patient what happened exactly today. Then you ask pre-syncope question, syncope question, and post-syncope question. Then you move to the differential diagnosis, severe CNS, and all other different differential diagnoses, including vasovagal, hypoglycemia, postural hypotension, anemia, and stress. And lastly, we always finish medicine cases with past medical history, SADMA, and family history. Okay, so pretty easy format. You will always remember the gist of it, which means hemodynamic stability, history of presenting complaint, which is syncope, then differential diagnosis, then past medical history, SADMA, and family history. That's the gist of this cluster. And other thing you will just remember. But this is the format that I always advise anyone to follow, so that there is some kind of relevance, because most of the time candidate, what they do, first they ask about syncope and they go for past medical history, SADMA, and family history. They forget the differential diagnosis in between. And that's the time in the history candidates usually get failed. Okay, so use the format, because this is the way you would ask in any real life scenario. You would not jump to the past medical history or family history without ruling out differential diagnosis. Making sense for everyone? And Dr. Mehta, yes, if you find, if you get a positive finding, still you are supposed to ask the differential diagnosis. And if you get any positive findings, you will ask a little bit more detailed about those findings. But definitely, yes, you are supposed to ask all the differential diagnoses one by one. Do we get complicated cases with multiple chronic disease? Not really. You don't get that much complicated conditions in the exam. Usually one diagnosis, but sometimes you can get multiple diagnoses in a same patient. You can take note while you are talking to the patient, but it doesn't look good, and you will waste a lot of time. Likely chance you will not be able to finish the task. Yes, this year only online exam. There is no face-to-face exam so far as far as I know. Okay, so your history is done. After that, in online exam, there will be two different kind of format. So first task is history from the patient. The second task, one would be physical examination. Card will be given on the screen. So once your history is done, they would provide the finding of physical examination just like this. So there will be a card on the screen. It will show all the positive findings that you have found from this patient. So physical examination finding can be given on the card, or in other situation, they can ask you that discuss what physical examination you would do in this patient, either with the patient or with the examiner. And after that, a physical examination card will be provided on the screen. So second task is a bit complicated. First task is easy, which means they will give you physical examination card. You will just read it silently, and then you move on to your next task. If that is not there, the other task would be, first you will need to tell the examiner that what physical exam you would do in this patient. And once you say that, a card will be provided on the screen. And on that card, all the findings will be given. You will just read the physical examination card silently, not loudly. And then you will go to the next task. And the next task would be give your diagnosis and DD, which is differential diagnosis. And sometimes there might be a fourth task asking for management. Okay? So this is the typical scenario. Now let's say we have to explain to the examiner that what physical examination we will do in this patient. So what will you say at that time? So once you finish talking to the patient, you will thank the patient. So you will say, thank you so much for all the information that you have given. Now I'm going to talk to my examiner and come back to you. So remember, examiner doesn't talk to you on online exam. You'll just say that this is what I'm going to do in this patient. So you'll say, dear examiner, I would like to do physical examination on this patient. First, I would do a general appearance, and I will look if the patient looks comfortable or in distress. I will check for any pallor, any icterus, any lymphadenopathy, any sign of dehydration. I will check his vitals, including pulse, blood pressure, respiratory rate, oxygen saturation, and temperature. I would now, because one of your DD in here is arrhythmia and also postural hypotension, you would say, I would check his blood pressure, both standing and sitting position, to rule out postural hypotension, and pulse rate with rhythm to rule out any arrhythmia. Okay, so this is just, you will include in here because this is your differential diagnosis. You can check the BMI, but not very important for this case. Then I would like to start examining the neck. I will check for any raised jugular venous pressure, and also I will listen for any carotid bruit. Then I will then I will examine the cardiovascular system. On inspection, I will check for any visible cardiac impulse. On palpation, I will check if the apex beat is normal in position, any palpable thrill, any parasternal heave or palpable P2. On auscultation, apart from S1 and S2, I will check for any other added sound like murmur. Then I will do a complete central nervous system exam, upper limb and lower limb, including the cranial nerves. And then I will finish with all other systemic examination as well. I would also order some office tests for this patient, including urine dipstick, blood sugar level, and a electrocardiogram. So that's how you will explain to the examiner if there is a task. That if they say that explain what physical examination you would do in this patient to your examiner, and then a card will be provided on the screen. So if that is the task, you will exactly say what I said here. And for any kind of cardiac question, this is our format. Okay, so general appearance, peak out, vitals, neck for JVP carotid bruit, CVS, because CVS is our main systemic exam. That's why we are doing it in details. And then CNS, other system office test, including urine dipstick, blood sugar, and ECG. Now, let's discuss a bit what is peak out. Time to time, you will listen to me that I'm saying peak out. So peak out is a mnemonic for pallor, icterus, cyanosis. Now, ideally, clubbing should be C, but we just write it for the purpose. So clubbing, lymph node, E for edema, and D for dehydration. So that's peak out. Now, you don't need to say all of them for every patient, just the relevant one. For this case, pallor is important because anemia is one of your DD. And then you can ask about clubbing, lymph node, edema, dehydration to everyone. Okay. But for this particular case, like for a syncope patient, definitely you will do a full cardiovascular and CNS exam. All right. So that's your format for physical examination. Now we will move into the task. And now we are moving into the cases. So first case is aortic stenosis. Let's see, you have got some question, Dr. Shumbal. Should we mention radio-radial delay, radiofemoral delay? Not for this kind of cases where you have theory, where you have history, physical exam, diagnosis, management. This is a long task. So in these cases, you don't need to be that much detail in physical examination explanation. There are just physical examination cases where we discuss each and everything, but that we will do later on in the course. Should we talk about positive finding while reading examination finding from card? No, we don't need to say it loud. But during your explanation, you can include that, like in the history, this is what I have found. In the physical examination, this is what I have found. And based on that, I believe, or most likely, you're having this condition. So in that way, you can include it, but you don't need to read it aloud. So no need to read the card loudly. Do we need to explain CNS in detail? No need. Yeah, so radiofemoral, radioradial, that's for coarctation of aorta, not for this kind of case. So far clear, everyone. So this is the format. Now we will use this format to do some cases under this cluster. Okay. So first one is aortic stenosis. You are a GP and your next patient is a 52-year-old male who is consulting about recent loss of consciousness. Take a focused history, physical examination. Now, this kind of the task will be different nowadays. So nowadays the task might be, as I said, could be physical examination card on the screen will be given, or you might need to explain the physical exam to the examiner. They can say that ask for necessary investigation that you want to do for this patient and give your diagnosis and management. Always remember the task is important. In every cases, you will only say or what has been asked in the task, nothing extra. Because if you say extra, it will not give you any mark. A lot of candidates, what they do, the task is history, physical examination on card, diagnosis and differential diagnosis. That's it. No management. But a lot of candidates, they feel like even though diagnosis and DD is the last task, I still need to talk about management. So examiner, they don't get very happy with that because it means that you did not read the task properly. And most importantly, when you are talking about management, when it is not a task, likely chance you have missed some important thing in other tasks. So eventually you will fail that case. So there is no need of saying anything extra rather than what has been asked in the task. Okay. Now, for this particular case, who has a loss of consciousness, and they said recent loss of consciousness in a 52-year-old male. So the positive point in the history was patient was playing tennis and then started to black out. He also having a shortness of breath on exertion for the last 2 months, complained chest tightness or chest pain. So you have got 3 important findings which usually we find in a aortic stenosis patient. What is that? Chest tightness, exertional dyspnea, and syncope. Along with that, when you do the physical exam, you can get a murmur of aortic stenosis in this patient. That will confirm the diagnosis. So physical examination, left apical impulse was displaced, but the main thing is this ejection systolic murmur in the aortic area radiating to the neck or carotid. So for aortic stenosis, the murmur that you get is called ejection systolic murmur, and definitely it's on the aortic area. So ejection systolic murmur on the aortic area which radiates to the neck or carotid, that's definitely aortic stenosis. Okay. So how you are going to explain this to the patient? So most of the time on the physical examination card, they will give you the finding that this patient has got this kind of murmur. So once you know that this is the patient has got a murmur, patient has got classic triad of aortic stenosis, you could be sure that this is aortic stenosis. So you can easily give the diagnosis to the patient. So how we explain it, that's very important. So our explanation should be something like that. So you can say that from history and physical examination, most likely you're having a condition called aortic stenosis. Or if you have more time, you can always say in this way, John, thank you so much for all the information that you have given to me. As you have told me that you suddenly lost consciousness and you have been having shortness of breath and chest pain during exertion. And during the physical examination, I also have found an abnormal sound in your heart known as murmur. I believe that most likely you are having a condition called aortic stenosis. Do you have any idea about it? No, doctor. Well, that's fine. Let me explain in detail. So, John, you know that we have got the heart in our left side, and our heart has got 4 chambers. Each of the chamber has a door-like structure called valve. Right? So, this is the heart, and heart has got 4 chambers. Now, you can't draw in online exam. That's a bummer, but you'll have to explain in as simple way as possible. Remember, in exam, if you're talking to a patient, you cannot use medical jargon. You can't ask the patient that do you know, like, have you got any murmur? So you can't just say murmur to the patient. You will have to explain, have you got any abnormal sound in your heart known as murmur? So that means you have to explain the medical jargon if you are saying a medical jargon to the patient. So your explanation should be as simple, as layman as possible. Okay? So you will say that we have got the heart on the left side of our chest. Heart has got 4 chambers. Each of the chamber has a door-like structure known as valve. In your case, the valve that controls the flow of blood from your heart to the biggest blood pipes known as aorta, called aortic valve, is narrowed. So in your case, the valve that controls the flow of blood from the heart to the aorta, which is one of the biggest blood pipes in our body, that has been narrowed. The valve that controls this flow is known as aortic valve. That is why the blood supply to the brain is reduced, causing this loss of consciousness that you are having. And also when you exercise, the demand of oxygen from the heart gets increased, but it is already narrowed, so it cannot supply enough blood and oxygen, which gives you the chest pain and shortness of breath. Always try to correlate the patient's symptoms to the explanation of the patient's condition. That is the best way of explaining a diagnosis, always. Because if you say a lot of pathophysiology about a condition, that will not make a lot of sense. But if you can explain to the patient that why I am getting shortness of breath or chest pain during playing tennis, that's the time patient will feel, yes, that I know then, so I know why I'm feeling this way. Okay, so idea of explaining a condition is correlate the patient's symptoms with the condition patient has got. Like in this case, we have explained why this patient getting loss of consciousness and why the patient has got chest pain and shortness of breath. Okay. Then you can say it could be due to other condition as well. Like many times, after giving the diagnosis, your next task would be giving differential diagnosis. If that is the case, then you don't need to say any of this line. You'll say that, well, it could be due to other causes as well. So then you'll explain all the differential diagnoses that you ruled out in this patient. So you can say that it could be related to heart rhythm disturbance, but again, in your case, you haven't got any racing of the heart, so it is very unlikely. It could be due to some other congenital heart condition, but in your case, the symptoms doesn't go with that. And also, we will do further investigation like a ECG to rule that out. It could be due to some brain-related condition like epilepsy or seizure, but when you lost consciousness, you did not bite your tongue, you did not lose your bowel or bladder motion. It could be due to stroke, but you did not have any weakness or any problem with your vision or speech. It could be some other causes like vasovagal syncope, but your symptoms doesn't go with that. It could be due to hypoglycemia or low blood sugar, but during these episodes when you lost consciousness, you did not skip your meal, nor you are a diagnosed patient of diabetes. So these are all very unlikely in your case. So that's one of the way to explaining differential diagnosis in the exam. Even if differential diagnosis is not a task, I always encourage everyone to at least say some differential diagnosis after finishing your explanation of the diagnosis. Like in this case, the last task was give diagnosis with management. So DD was not a task, but still you can always say that it could be due to other condition like heart rhythm disturbance. It could be due to some structural defect of the heart. It could be due to some coronary artery disease or there might be a lack of blood supply to the heart arteries. Could be some brain related conditions, but in your case, these are all very unlikely. Okay, so at least say some DD is always good. Now, if this is a hospital setting, so when you read a task or when you read the question, it is also very important to know where are you? Are you in the emergency department or are you in a GP clinic? Because your management depends on that. Something like aortic stenosis, patient usually will need to be admitted to the hospital for further workup. Okay, especially if patient getting symptoms. Asymptomatic patient, the GP can manage that as an outpatient. But if it is a symptomatic patient, like losing consciousness, that's serious. So for that case, you will need to send the patient to the hospital. So if it is the emergency department, then you will say that because you are losing consciousness, this is urgent that we admit you to the hospital to confirm the diagnosis and rule out other diagnoses. I will also call my senior. Now, always remember you are the junior most doctor in AMC clinical exam. You are not the specialist there. And you don't act like a specialist in the exam. If you do, you will fail the exam without any question. And that is one of the other reason why most of the specialists fail AMC clinical exam. Because many of you are specialists in your country. And you do all the management for a lot of these cases. But if you act like a specialist in this exam, you will fail. Even if you know everything that this patient needs to be done, still you can't just manage it by yourself, because they will write you in the task that you are a HMO or you are a junior medical officer in an emergency department and this patient came to you. So if you are a junior doctor in the ED, all you can do is you can give a provisional diagnosis and everything needs to be discussed with your senior, and you will need to inform the specialist for further management. So let's say it is an emergency department setting. So you will first say that I'm going to admit you to the hospital. I will call my senior and discuss this case with him. And also we will involve a heart specialist for further management. In the meantime, we will do some blood test and some other imaging, including a full blood examination. We will check your kidney function, liver function. We will do an electrocardiogram to check the electrical impulse of your heart, a chest X-ray, and an echocardiogram, which is basically an ultrasound of your heart to confirm the diagnosis. Now, remember, up to chest X-ray, you can do. As a junior doctor, you can order all of this after talking to your registrar. So you will say that, in the meantime, I'm going to order some blood tests, including this, and also we will do a ECG and a chest X-ray. Once the specialist is here, most likely he will want to confirm the diagnosis by doing an echocardiogram of the heart. Echocardiogram is a non-invasive procedure where they will just use an ultrasound probe to find out exactly which valve is narrowed and how much narrowed it is. And based on that, further management will be decided by the cardiologist. Okay? If it is not severely narrowed, and if the symptoms are not severe, most of the time, cardiologist will keep you under close surveillance and you will be reviewed by the GP once you are discharged from the hospital. But if the aortic stenosis, if the valve is severely narrowed and you are getting multiple episodes of loss of consciousness, then definitely this will need a valve replacement. But I'm the junior doctor in here. I'm not going to discuss all of this with you. The specialist will decide and they will discuss in further about if any of these things are needed. Do you have any questions? Okay, so that should be your approach in the exam. You will say that what are the options this case have. This case can be medically managed, but most of the time this case will be surgically managed with a aortic valve replacement. But this is not your job to decide, and you can't decide before you get the echocardiogram, and definitely cardiologist is the specialist who is going to decide about the management. But as a junior doctor, you can give the whole picture that what's going to happen, but the decision is up to the cardiologist. So you'll have to involve your senior, you will have to involve the specialist for this kind of cases. Okay? This is understandable for everyone, that I'm trying to give you the whole picture. One by one, you will get an understanding about these cases. What if this was a GP setting? If this was a GP setting, all you need to add is that I'm going to send you to the hospital for further assessment, where you will be admitted and seen by a cardiologist. Most likely they will do this investigation, and then based on the echocardiogram, further management will be decided by the cardiologist. Okay? So that's aortic stenosis case. Any question? On physical examination, will they give you the auscultation finding as above? Yes. Most of the time, they will give you the finding. And with cardiac cages, can we do a respiratory system? Definitely, you can do it. What kind of samples, Dr. Navjot? We don't send any samples from GP clinic. Ideally, for this case, it's not urgent. Investigations, no need. If you have done any investigations already, then you can send a referral letter with the investigations in it. But if you haven't done, then the hospital will do it anyway. Yes, if it is an unstable patient in a GP clinic, yes, GP clinic they have to do a resuscitation as well. But GP clinic has its own limitation. They can't do the whole thing that a emergency department can do. All right, everyone. Now we are going to take a 10-minute break. And after the break, we will do further cases under this cluster. Okay? And in between this, I want you guys to just think about the differential diagnosis. Think about like how you're going to start asking the questions and everything. Okay? Let's take a 10-minute break. All right, everyone, let's restart. The next case is prolonged QT syndrome. A 19-year-old girl comes to the ED because she fell unconscious 2 days ago while she was climbing up a mountain. So this is a typical scenario of either a HOCM or a prolonged QT syndrome, because those are common in younger patients, and most of the time they will have a syncopal attack with some kind of like a exertional activities. Okay. Now, the task is more or less similar. Just 1 second, guys. Now, if you have got a patient like this, so it will be falling under the same cluster of syncope. The positive points would be sudden loss of consciousness while she was climbing up the stairs. 3 episodes so far, doing different things each time. So you'll get an idea that what are the scenarios or what are the episodes that she has got so far and what she was exactly doing in each of these episodes. So get a full idea. Apart from sudden loss of consciousness, there was no shortness of breath, no chest pain, no palpitation, but there was a history of unknown heart disease in maternal uncle, and you will get some kind of sudden cardiac death in the family. Physical examination did not show any murmur, but they gave you a ECG showing prolonged QT. Now, we are not going to discuss ECG today. The next class, we will discuss a bit of ECG, and also, as promised, we will give you our MCQ ECG class recording in your portal once you join the course, and you can also go through the basics of ECG if you like from that recording. Now, because all of you passed MCQ, so I hope you have a basic idea on ECG. That's very important part of your MCQ preparation. Now, when we have a ECG like that in the exam, we need to know how to read it, because if you don't read it properly, then you will not be able to get the diagnosis. When you get an unconscious or syncope patient, then you are not looking for ST elevation in a 19-year-old girl. So in your head, you will need to think that what's the likely cause of presentation for this patient. So I'm not thinking about a myocardial infarction in a 19-year-old girl, right? So it could be arrhythmia, and HOCM, we don't get any finding on ECG, except there might be a bit of left ventricular hypertrophy. Then we don't get any other finding like aortic stenosis. It's common in elderly patient. So again, not very important for this. And ECG, you don't get any finding. So it could be prolonged QT syndrome also, right? So thinking in that way, you will look into the ECG. When you have got a patient without a chest pain, always look at the long lead. So long lead is the lead where you can see the full lead like this. But all other lead like lead 1, lead 2, 3, you can see this just a bit. You can't see the full lead like this lead 2 in here. So for arrhythmia case or syncope case, I would suggest to look at the long lead first. But if it is a chest pain case, then you would look at the anterior lead first, which is V1 to V6. And you look for ST elevation. So in lead 2, what you will look for, first of all, look at, you can see the P wave here. Now go back to the normal ECG. So normal ECG, that's the P wave, followed by QRS complex, and then there is a T wave, right? So this is the normal one. In a ECG, there are some interval, there are some segment. So this is PR interval. So starting of the P wave and starting of the R wave, that's PR interval. And then there is QT interval where it's the starting of the Q wave and finishing of the T wave. So that's QT interval. For this case, QT interval is important. And then you have got this QRS complex over here. Once you see the long lead, first you look at the normal part of the ECG. So you can see the P wave, then there is QRS complex, then there is T wave, and same every P wave is followed by a QRS complex, right? So that's fine. You can also see there is no ST segment elevation in here. That's also fine. Look at the rate and rhythm. So to check the rhythm, you will need to see that this is R wave, this is R wave, this is R wave. If it is regular rhythm or not. So to check the regular rhythm, you check the how many large box is there in between two RR interval. So you can see one large, two large box, three, four, at least four large box with a bit of two small box. Check the other one. So 1, 2, 3, 4 and bit of and 2 small. So you can see that rhythm is regular. So quickly you check the rhythm. So rhythm regular, and you can see there is P wave, QRS, T wave. So everything looks normal in this ECG. Quickly check the V1 to V6 for any ST wave changes. So what is ST? ST is this one. And you can see here there is P wave followed by QRS complex, and then there is a T wave. And there is no ST segment elevation because this is the isoelectric line. If the ST segment is along the isoelectric line, that means it is normal. In the V2, same. V2, there is a P followed by QRS complex, ST, and then there is T. Same in V3, there is no ST segment problem. V4, V5, V6. So there is no ST elevation in this patient that we know. We know that rhythm regular. We know there is all P, QRS, everything is fine. So it means that you can't find out the cause. When you can't find out the cause, you look at the QT interval. In a normal ECG, QT interval is, normal QT is between 8 to 11 small square. Now look at this QT interval from anyone here. So this is the start of the Q wave, and this is the finishing of the T wave. And now find out how much small square is there in between. So there is 5 small square, 10 small square, 15 small square. So we know that up to 11 is normal. So this patient has got 15 small square QT interval. So that gives you a diagnosis that this is a prolonged QT syndrome. Okay. So when I discussed it, it took a lot of time. But when you will think it in the exam, you will quickly check everything. So you will quickly check for any ST elevation in V1 to V6. There will be none. Then you come to the long lead. In the long lead, you check the rhythm. Rhythm looks regular. Nothing is abnormal. Look at the QT interval. If it is prolonged, that means it is a prolonged QT syndrome. Okay. Once you have got the diagnosis, you will explain to the patient that, Jenny, from history and physical examination, and also the electrocardiogram that we have done, most likely the cause of your unconsciousness is due to a condition called prolonged QT syndrome. Do you know about it? No, doctor. Well, you know that when we put those electric leads on your chest, we actually checked the electrical activity of your heart, known as ECG or electrocardiogram. So our heart is located on the left side of our chest, and it has electrical activity to pump the blood to the whole body. And the ECG has got different part which represents different component of this activity. In your case, the part that we call QT interval is markedly prolonged, and that is why we are calling it prolonged QT syndrome. This condition is commonly associated with abnormal heart rhythm, resulting in impaired pumping of blood, causing frequent collapse like in your case. See that how we are explaining in a very simple way. Even a lot of doctors don't understand ECG that well. So you don't need to explain ECG to a patient. You just say as simple as possible. So say that you have got a prolonged QT syndrome. The heart has got electrical activity to pump the blood in our whole body. The ECG has different part which represents different component of this electrical activity. In your case, the part that we call QT interval, that is prolonged. That's why we are calling it prolonged QT syndrome. This condition is associated with abnormal heart rhythm, which causes impaired pumping of blood to the whole body. So your brain also doesn't get enough blood. So that's why you get frequent collapse. Are you with me so far? Are you understanding me? Yes, doctor. Always check if the patient is understanding you. Then you can explain. If you want, you can also give some differential diagnosis in here and say that sometimes this condition can run in the family as well, but sometimes it can be due to some medication, could be due to dehydration, could be also due to salt and water imbalance. Unfortunately, this condition sometimes can also have serious consequences. That's why I need to admit you to the hospital and I will call the heart specialist to review you. Please don't get scared. You are in safe hand. And this is not an uncommon condition. And we have a very good team of cardiologists who will manage your condition. So reassurance is a very important part of your explanation. Always remember, you can't just say everything like a robot in the exam. You have to consider the patient, who you are giving the diagnosis, how he or she is feeling. So your reassurance will matter a lot for that particular patient. Say that the specialist might also want to do few investigations such as checking your full blood count, your salt and mineral level, kidney function, blood sugar level, and also they can do an echocardiogram of your heart. You might want to start you on a medication called beta blocker to reduce the heart rate and also to make sure your heart get enough time to feel properly. If that doesn't work, then there are some specialized method of managing this heart rhythm. Sometimes that is what we call as cardiac pacing. Now, this is all very new for you, and I don't want to discuss all of it just yet because the specialist will come and discuss this in detail with you. But now you know that there are options of medical treatment, and if that doesn't work, then there are some specialized equipment that also we can put you on. If all the investigations come normal and we can't find out any cause behind it, then most likely you had it from your birth, known as congenital prolonged QT syndrome. And in that case, we will also recommend all the family members to screen for this condition as well. Once you are discharged from the hospital, we will write a letter to your GP and he will follow you up regularly. Do you have any questions? Okay, so that will be the case for prolonged QT syndrome. Any question? Should we ask them to refrain from physical activity? Yes, yes, you will definitely ask them to refrain from this kind of physical activity. Medication is beta blocker because beta blocker, it can increase the QT interval. So when the heart rate is low by the beta blocker, then the beta blocker has a specific way to increase the QT interval by itself. Yes, we ask about the medication, right? We are, as part of the format, we ask about the medication. So if there is any medication that patient is on which can increase the QT, definitely that will be your cause to look at. Like there is a lot of medication which can increase the QT. But for a 19-year-old, they don't take those medications like antiarrhythmic drugs, some of the antibiotic. So it's not quite common for a 19-year-old to take antiarrhythmic drugs which can cause this prolonged QT. But definitely, medication is there. We are giving that in the cause we are discussing that it could be due to medication, it could be due to dehydration, salt and minerals. So we'll be checking everything to find out any specific cause behind it. For prolonged QT syndrome, Dr. Sherry, definitely the QT syndrome will be more than 11 square. There is no need of giving confidentiality in a cardiac case, Dr. Gottstein. Confidentiality is mainly for psychiatric cases, and sometimes we use it for gynae cases. If there is a medication causing prolonged QT syndrome, then yes, we will stop it, but we will first consult with a cardiologist if it is a cardiac medication. All right, now moving on to postural hypotension. Confidentiality is for psychiatry and sometimes in gynae cases. It's not always that if heart rate is low, QT interval will also be prolonged. It's not like that. It's the other way around. Okay, Dr. Sherry? So there is a lot of patients who can have sinus bradycardia, but their QT will be normal. So just because there is bradycardia doesn't necessarily mean QT has to be prolonged. It's not like that. No, they will give you the ECG in the exam and you will need to get the diagnosis. They will not give you that diagnosis, unfortunately. So to diagnose prolonged QT, you need to first find out the QT interval. That's the point of discussing this ECG, right? So bradycardia is different part, but the only time you can say prolonged QT syndrome if you can see the QT interval is prolonged. Okay, not every bradycardia patient will have a prolonged QT syndrome. That's not like that. Okay, moving on to postural hypotension. Postural hypertension is a very important case and it comes in exam a lot. So there are a lot of ways that it can come. One, that patient can come to you with dizziness. So dizziness and syncope, it will be the similar kind of format. Okay, so you will use the same differential diagnosis, same format for dizziness case as well. 65-year-old man comes to you because he had a fall yesterday. So it can come as a fall as well. So the history in this case was patient feels dizzy when standing from a sitting or lying position. Now there are lots of causes of postural hypotension. So postural hypotension can be due to if a patient is having, let's say that active loss of blood volume. Like if the patient is having severe vomiting, severe diarrhea, burn, active bleeding. Okay, so hypovolemia can be a cause of postural hypotension. The second, it could be medication induced. So polypharmacy, which is most common in elderly patients, taking lot of medications, and many of them are hypovolemic medication. That can be the cause. The third cause, if someone is having active infection like septicemia, that can also reduce the blood pressure. Fourth cause, it could be like sometimes diabetic autoneuropathy can come as postural hypotension. So these are the main one that you want to rule out. Sometimes even anemic patient can have postural hypotension. Okay, so these are the main differential diagnosis, or these are the main causes that you will look for. Postural hypotension is a diagnosis, but there is a cause behind it. So there has to be something which is causing this, and finding out the cause is important to manage that postural hypotension. All right. So you have got a patient who is feeling dizzy while changing from sitting to standing position. Patient also says in the history that he is diabetic for many years, but well controlled. Medication list is metformin, aspirin, diuretics, ACE inhibitor. So you have got diuretics which can cause hypovolemia, ACE inhibitor can cause it too. Metformin can cause hypoglycemia if they're taking prolonged or increased dose of it. History of heartburn, loose stool, no blood in stool. Physical examination, only postural drop, nothing else. So that's one case. The other case was patient was sitting in a church. While standing from sitting position, patient collapsed. The other case was patient was taking risperidone for psychiatric problem and now having history of dizziness. Risperidone is a very common medication which can cause postural hypotension. Okay, so these are the cases which came in exam like throughout the years and years. But any kind of case can come with any kind of information which you should be prepared. So how will you explain this? So your history will be exactly same like what we have done so far. So you will follow the format. So first vitals, then you will ask about what happened before dizziness or before having the fall, what happened during fall and after fall. Then you go to the differential diagnosis, you will ask severe CNS cause, and then you will come to the postural hypotension. And you will find out patient feels dizzy with changing position. Once you find that out, you will try to find out the cause of this. So in the cause, you know that active infection, vomiting, diarrhea can cause it. So you can ask the patient that any recent severe vomiting or diarrhea, any history of bleeding from anywhere, okay? And also you can ask about any fever, any recent flu-like illness. After that, you will finish with all other differential diagnoses that you ask. So anemia, you will ask about stress and everything. Then you will come to the past medical history. In the past medical history, you will find out this patient was diabetic for many years. And then you will ask questions about it. So how long you are diabetic? Is it well controlled? How is your blood sugar level regularly? What medications do you take for diabetes? Do you take it regularly with prescribed dose? Any chance that you might have increased the dose lately? Okay. So ask about diabetic questions, because diabetic autoneuropathy is also one of your DD. You might also ask few questions regarding diabetic autoneuropathy. Diabetic autoneuropathy patient also have some kind of indigestion, bloating, heartburn or reflux. They can have diarrhea, they can have constipation, they can have sexual dysfunction. So all these questions you can also ask if you get diabetes positive in the history. So you can ask that, do you suffer from heartburn or reflux? Any bloating sensation in the tummy? Any indigestion? Have you noticed any diarrhea or constipation? Any difficulty with your sexual life? So all these questions you can definitely ask, okay? After that, past medical history, SADMA, smoking, alcohol, and medication. So you will come to the medication history. You will ask, do you take any medications? Then patient will give you all the medication list. And you need to ask, is there any medication which you have started very recently? Any medication which you have increased the dose? Okay. Any chance you might have taken any medications more than usual? So that will give you an idea that if patient used to take diuretics and now the GP has started a new ACE inhibitor, so that could be the cause of postural drop. So you'll need to dig it out. That's the main thing. So you'll find this out from the history, and then you will explain that from history and physical exam, most likely the cause of your dizziness is what we call as postural hypotension. This is a condition in which there is a sudden drop of blood pressure when you change your position from sitting to a standing position. It could be due to many reasons, like could be severe vomiting, diarrhea, high fever, strenuous exercise, but in your case, most likely it is due to multiple medications that you have been taking. Now, if there is any medications that you have found that can be the culprit, you can always say that, like you are taking 2 blood pressure lowering medication and both of them can drop your blood pressure significantly. So I'm thinking any of these medication could be the cause of this. Also, as you are diabetic, it could be due to another condition called diabetic autoneuropathy, which can manifest as heartburn, bloating, diarrhea, constipation, difficulty with urination, and also sexual dysfunction. But in your case, you say that your blood sugar is well controlled, so it is unlikely. This type of dizziness or fall could be due to other condition as well. Then you can give some differential and say why it is unlikely. Then you will say that, well, as part of the management, first of all, I would like to start with some blood test. So I will send you for full blood examination, inflammatory marker, checking your liver and kidney function, your thyroid function, blood sugar level, and also an ECG to rule out any cardiac causes behind it. If everything comes normal and we can't find out any cause, then this is most likely due to the medication. So in that case, I would consult with your specialist to review the medication to see if we can change the medication or we can reduce the dose of the medication. Okay, so that's the first case. If it is due to that, then this is how we are going to manage the patient. So investigation, then review the medication to change or reduce the dose. For any kind of postural hypertension, we can always use this advice at the end. We can always say that to prevent further episodes, it's very important that you take your medication exactly as prescribed, have a routine to take the medication at the same time every day, never stop any drug abruptly, and you can follow this half-minute rule or 30-second rule. For the first case, this 30-second rule will be the only thing that you will say. You will not talk about medication and everything because this is not the patient's fault. The GP started the antihypertensive, so that's most likely the cause of the drop. Okay, but if patient increased the dose by himself or patient missed a dose and then doubled the dose next day, then definitely you will talk about taking the medication as prescribed, have a routine to take the medication same time every day. Okay, so you can add them in that case. So what is the half-minute rule in postural hypotension? When you get up in the morning, sit up slowly and stay for 30 seconds there. Put the legs over the side of the bed for 30 seconds and then slowly get up, and then you walk to prevent any dizziness in future. So it means that gradually standing, not abrupt standing, that will also prevent this kind of dizziness episode. Okay? So that is this case all about. Any question with postural hypertension, guys? Sexual dysfunction can happen in both men and women. Yes, we can definitely ask it, but not very necessary because it's mostly erectile dysfunction is the problem for autonomic neuropathy. So that's postural hypertension. Moving on to vasovagal syncope case. This is also quite important for exam. 18-year-old girl, sorry, so can we discontinue the medication till the specialist come? This kind of case most likely will come to the GP clinic. So definitely, if you think that there is a medication which is causing it and patient's blood pressure is too low, which will be in this case, yes, you can withdraw the medication, like either diuretics or the ACE inhibitor. Withdraw one of the medication until patient see the specialist, and then you can review the patient in few days time to see that if the blood pressure is coming up. Vasovagal syncope, 18-year-old girl fainted during marathon running during annual sports. Now fully recovered, mother came to consult you. Take history, physical exam, tell possible causes. So you can see from the question that patient was running marathon and then had a faint. So just by looking at the question, you know that likely chance it could be a vasovagal syncope. But it could be anything. So you will just follow the syncope cluster. You will ask all the questions, and the finding that you will get is it was a hot sunny day and patient was running marathon and she skipped her breakfast before running. So one is running marathon in a hot sunny day, that's vasovagal syncope. On the other hand, patient did not take breakfast, so she most likely got hypoglycemic. For a girl or female patient who is having syncopal attack, we should also ask about their period question. So you will ask the patient, so I'm going to ask you some private questions about your period and sexual life. Is that okay with you? Please be reassured that this is confidential. So when was your last menstrual period? Patient says 2 weeks ago. Is it regular or irregular? Regular. Are you sexually active? Yes, doctor. Is there any chance that you could be pregnant? Do you use any contraceptive pill? Also in the period question, do you suffer from excessive bleeding during your period? To rule out menorrhagia. Menorrhagia can cause iron deficiency anemia. That sometimes can be a cause of syncope in this young female patient. And that was also positive in this case. So a lot of findings can be given in a case, and you need to find out all of them. So for a female patient who is having syncope, definitely we will ask their period. If they're having menorrhagia, like heavy bleeding during period, is there any chance that this patient can be pregnant? And she might having an ectopic pregnancy. That's why she had a syncope. We don't know. So we should find that out. So ask about last menstrual period. Is it regular? Any heavy bleeding? Are you sexually active? Any chance you can be pregnant? Are you using any contraceptive pill? Okay. So these questions you will add. In this particular case, you will find out patient also has heavy bleeding during her period. So 3 findings: vasovagal, hypoglycemia, and most likely menorrhagia causing anemia. And in the physical exam, they have given you that blood sugar is 3.6. Normal blood sugar means that it has to be at least above 4. Less than 4 millimole per liter means patient is hypoglycemic. So still now at the moment, the child is hypoglycemic. So if you get a physical examination finding like this in the exam, where it shows patient is hypoglycemic, you will need to, in the management, you will need to offer some glucose drink to that patient. That's a key step. Okay? So you will say that from the history physical examination, most likely the temporary loss of consciousness that your daughter experienced today was syncope. There are many reasons which can cause it, but in your daughter case, it could be 2 possibilities. Now, in here it was 2, sometimes it can be 3. One is called vasovagal syncope. In this condition, in response to certain trigger, such as overexerting in a hot sunny weather, can stimulate a nerve in the body, which causes pooling of blood in the legs. If there is pooling of blood in the leg, it causes decreased return of blood towards the heart. And if heart doesn't get enough blood, then heart cannot pump out enough blood to the brain. So brain temporarily get compromised, which causes this sudden faintness or collapse. Please don't get scared about this mechanism. This is a very common cause of fainting, and there is nothing you need to worry about. You just need to be careful from the next time that she is more prone to get this kind of attack. On the other hand, we also find out that she's still having low blood sugar. And you say that she skipped the breakfast before going for the marathon. That's most likely exacerbated this syncopal attack or fainting in her. Because I'm still getting her blood sugar low, I would like to offer her some glucose drink and recheck the blood sugar afterwards. If you get finding of menorrhagia, you will also say, on the other hand, I also find out from the history that your daughter is bleeding heavily during her period. Something like that also can lead to anemia in a child. So it's a good idea that we check her hemoglobin level and also the iron level to make sure she is not anemic. Okay, so that's how you will explain the causes in this case. Any question? Now it depends. So this kind of case, usually it will be not a 18-year-old. If mother is here to talk about the daughter, most of the time it will be 16 or 17-year-old girl. In that case, definitely you will talk to the mother. And in exam, only one role player will be there, either mother or daughter. So if it is a 18-year-old, then you have to take permission from the daughter to talk with the mother. Okay, so if mother is the role player only and daughter is not there, you'll need to ask the mother that because your daughter is 18-year-old, I need to make sure that you have the consent to talk about your daughter. So can you please tell me that if you have the consent to talk about your daughter? If the role player say, yes, I have the consent to talk about my daughter, then you will just continue. Okay. Yeah, even if patient is menopausal, which is unlikely in this case, we ask the menstrual history, but we will discuss that in gynae class. Okay, so that is this vasovagal syncope case. The another case which also fall under this cluster is recurrent fall. And recurrent fall comes in exam a lot. Like it's kind of a paid case for exam. So you'll need to remember the differential diagnosis for recurrent fall. It's more or less same as the syncope cluster, but a few things we have to add in here. So recurrent fall can be due to polypharmacy, that's most common in elderly patient, can be due to postural hypotension, which can be due to any of these causes. Could be vasovagal syncope, CNS CVS like before. It could be endocrine related, like hypoglycemia. It could be diabetic complication, like diabetic retinopathy, so patient can't see properly, so that's why they fall. Could be peripheral neuropathy. Could be electrolyte abnormality due to vomiting or diarrhea, anemia. Sometimes it could be home situation, like in the home, patient might have a loose carpet, so that's why they are falling. They might have poor lighting in house, so at night they can't see properly, so that's why they are falling. Sometimes they can have a loose handrail of the stair, so they can fall, or they might not have any handrail at all. So all of these home situations, we don't even think about it when we are finding a patient who has recurrent fall, but sometimes this might be the only cause why they are having fall. Okay, so we will need to consider that. If a patient has got abnormal vision or abnormal hearing, that can be a cause of recurrent fall. And elderly patient, all of them has got some joint problem like osteoarthritis, so that can be a cause of fall as well. So these are all the differential diagnoses of recurrent fall that we need to ask. So the history will be more or less same. So you will make sure patient is vitally stable, reassure the patient that you are going to take care of him, and then ask about the fall question. So find out, first of all, can you tell me about this recurrent fall that you have got? How many falls so far? And can you explain all the fall that what were you doing in each time? So get a basic idea about the fall episodes and then ask about what happened before the fall, during fall, after fall. Then you will ask all the differential diagnoses one by one. So CVS questions you know already, CNS questions you know. For postural hypotension, do you feel dizzy when you change your position? Any fever, vomiting, diarrhea, any bleeding from anywhere? For anemia, do you feel tired and fatigued? And ask all other DD accordingly. Then when you come to the past medical history, you will ask about any history of diabetes, heart condition, high blood pressure. You will find out in some cases that patient might be diabetic. So then you will again ask the detail of diabetes. So how long you are diagnosed? Is it well controlled? Are you regular with your specialist? Do you take any medication? What medication are you taking? Any problem with your vision? Any numbness, tingling sensation in your foot? Very important question. There is a case in the exam where patient has diabetic retinopathy and diabetic peripheral neuropathy, which is causing this fall. So those patients will have difficulty with vision. They will have numbness, tingling sensation on their feet. Find out their full medication history because polypharmacy can be the cause of fall as well. And lastly, ask about their home situation. So any loose carpet at your home, any poor lighting, any joint pain or joint stiffness, any difficulty with walking or keeping balance. Ask about smoking, alcohol, and recreational drugs. And for any elderly patient, support is very important. So who do you live with at home? Do you have enough support? Okay. So that will be the recurrent fall history. The physical examination of recurrent fall is a bit different. So you will ask about the general appearance, vitals, BMI, fecal. Those things are fine, but you will need to check their eye. So in the eye, you will be looking for their visual acuity, visual field, and fundoscopy. Why fundoscopy? To find out any diabetic retinopathy. Then quickly we will do the CVS exam, CNS exam, mainly looking for any diabetic peripheral neuropathy. We will also do a musculoskeletal exam to check for any joint pain or joint tenderness. And definitely in the office test, you will check the blood sugar level, urine dipstick, and even you can do a ECG if you like. Okay, so this is the only thing that will be added in the physical exam. So the positive point in the history was 3 episodes of fall so far, diabetic for 10 years, numbness tingling positive, and vision problem positive. Also has knee joint pain because of osteoarthritis, history of a stroke, taking physiotherapy now. So that's also one of the other factors that if a patient has a stroke, they can have difficulty with their balance. In the physical exam, fundoscopy shows retinopathy, peripheral neuropathy positive, and blood sugar is very high, 16. So how will you explain this condition? So you will say that from history physical exam, most likely the cause of your recurrent fall is due to uncontrolled blood sugar causing peripheral neuropathy. In this condition, the nerve that supply your lower legs get affected, causes tingling numbness sensation. That's why sometimes you might not even feel where you have been stepping. Also, we have found some eye changes related to diabetes, which is affecting your vision. On the other hand, you have knee joint changes, which can also lead to recurrent fall. So these are most likely the causes where you are having recurrent fall, but it could be due to this as well. As part of management, usually management doesn't come in exam, but if it does, then as part of management, First of all, you're in a GP setting. So you will order some necessary investigation. You will check the full blood count, inflammatory marker, liver kidney function, thyroid function. You will check HbA1c to check the diabetes control for this patient. You will check for any microalbuminuria because this patient has uncontrolled diabetes. You will do a ECG as well. Okay. Once this is done, you will need to organize a recurrent fall team for this patient. So you will organize a recurrent fall team, and recurrent fall team will comprises of you as a GP, who is the center of all the care, and then also a diabetic specialist who will review the medication and change it accordingly, a diabetic educator for this patient so that he understands the importance of maintaining the diabetes under control, a podiatrist who will show him the foot care because he's getting the peripheral neuropathy, okay, an optometrist who can check the eye properly, and even an ophthalmologist to check that, and also some allied health team, including a physiotherapist who can help the patient to have more muscle strength so that the balance problem can be sorted out. Occupational therapist will come at home and check the home for any poor lighting, any need of a handrail on the stairs, how is the bathroom, if it is slippery or not, okay? And they will change it accordingly. A social worker who can also help the patient for daily chores and daily activities. So this is the whole recurrent fall team who will take care of the patient so that this fall can be prevented. Okay? So that will be the management more or less for this kind of case. So that's all under this cluster that we are going to discuss today. Did you guys get an understanding that how just a simple one format, you did not need to take any history, you did not need to learn about physical exam, only thing that you need to memorize or remember is the explanation. So that's our cluster-wise approach. And in this way, we will finish most of the topic that can ever come in your exam. So the next class, we will have two clusters. One is palpitation cluster and another is chest pain cluster. Okay, those are very, very important cluster as well. The routine of classes has already been given. Dr. I don't know what's your name, 911. So now let me show you our course details and also the class schedules if you have any questions about it. Do you guys have any questions about the course? So I hope that you are enjoying the session so far, but this is just the start of it. It will take time for you to understand everything. And the cases that we are doing, I want you guys to start doing role play of this with your study partner. So you must know by now that how to do role play. So you start doing the role play, start finishing the cases in time, and it's not very hard as long as you have a proper guideline. How many DD do we need to provide in exam? No, 2 is not enough. Okay, so at least add 4 to 5. That's minimum. No, with the course you will not need any other book. Only one book you can have. That's your handbook. So that's the only book that you will need. Except that, nothing else. The notes are enough for passing this exam. Yeah, the AMC Clinical Handbook. And Dr. Sharon, the access is taking a time for, at the moment, it's taking at least a 1 week time for giving anyone access to the portal. So please give us some time. And if it is 5 days already that you have paid, you have informed us that you have made an account in the portal, then please give us another message or an email so that we can keep an eye on that. Okay. Enrollment email. Did you send me a message, Dr. Sachini, or what did you do? Um, okay. It might take a bit of time because sometimes even like sending the email can take 2 to 3 days. Has it been more than that, Dr. Sachini? Okay. Send an inbox again that you haven't got any email. Okay, I will have a look. All right, let me discuss the course details first, and then we will answer your questions again. So this is a 5 months course. The course has already started from 10th of March. The trial class was taken on 25th. The recording is already given in our Facebook group. I will show you where to find it. This is the schedule of our free 2-week sessions, which we are currently doing. So we had 10th March, 12th March, and 13th March today. And then there is 4 more classes as well. The classes are taken from 8:30 to 10:30 p.m. Sydney time. The Zoom ID usually will be given in our Facebook group. All the classes are recorded, so if anyone misses it, it will be given in the portal. For free 2-week session, we also give the recordings in the Facebook group. Now, our AMC clinical course is a combination of each and everything that a candidate need to pass the exam. We can definitely say that there is nothing extra that you need for this exam. Because we have a huge amount of collection of questions, discussions, classes. That's like most of the candidate even can't finish those. So there is a lot. So the course will include a full theory based on cluster-wise approach like today. We will do role play of recent and past important cases based on cluster and also random. So you had a random class with Dr. Cynthia yesterday. So she usually do the random role plays. She will mainly focus on 2024 important cases, but in our portal, you will get the last 4 years questions, last four years role play classes that Dr. Cynthia has taken. And that has more than 300 cases. And there is no exam in the world that you will get something new out of that, because it has every kind of case. Okay, so if you can finish those, that's really, really good. Physical examination, we take 1 month for physical exam, which is really good. Our physical examination, the notes are one of the best. And if you can finish the physical examinations and you can deliver it in the exam, you will pass it. And we have got a recent candidate who passed in her February exam. She passed all the 4 physical examinations. And she said that the notes that we had, she followed each and everything, and all her physical examination was passed. So it's not just she. We have seen a lot of candidates. Most of the first-time candidates fail the physical examination cases, but our candidates, they don't. Okay, because we take enough time on that. Online mock exams, then obviously recordings of these classes will be there. Even after you finish the course, there will be extra 5 more months of video access, so which is like more than enough for you to finish anything that you are left with. We also have discussion on job hunting, CPD hours, as we discussed, course completion certificate. And if you don't have 5 months before your exam, we always provide, if you pay full amount initially, you will get everything, including the previous batch recording classes. So any theory class, any role play session that has been taken in the last batch, it will be provided to you from the day one. Okay, but it's only for full paid students, not the installment ones. So that's a very good one, and you can finish the class within 1 to 2 months in your own pace if you like. Classes are taken 3 days a week currently. So we are taking Wednesday, Friday, and sometimes Sunday. Okay, the role play class sometimes can get a little bit differ, but theory classes are always Friday and Wednesday. Okay, so that's most of it. If you want to enroll, then this is our email. So send an email to this firstaidamc4536@outlook.com, or you can also send a message to my Facebook. So if you're a member of this First Aid AMC clinical group, you can easily find me here with all the posts. So you can just go over here and send an inbox. Then I can also help with the enrollment. Okay. Other than that, this group has all the course details, all the classes, schedules, everything is uploaded here. So you can also see. So the details that I have just read, it's also given in here. This is the recording of our trial class that's over here. And then the class schedules for these 2-week sessions are also given here. Okay, so you can have a look. This is the Zoom ID that is given. So that's everything given in this group. If you're looking for our recorded classes, you can always search in here, just write recording, and all the recorded classes will come up. Okay. So any questions? Is there any group for role plays? Yes, there will be groups, but it's not group role play. Remember, group role play will take a long time and you will just waste a lot of time. So the best way to do role play is get at least 1 or 2 study partner and then do a closed role play. So doing a role play in a group who has 10 people, you'll not be able to just do a 1 role play in a day. And that's just a waste of time. So the idea is to get a small group of study partner and then frequently do the role play. 3 is the best number. Okay. The ECG class we don't take in detail because it's a part of MCQ, not a part of clinical exam, but we will give you a recorded class for ECG, which we take in MCQ session. But we will discuss the important ECG that comes in exam. The psychiatry note, it was missing in the portal, but now it has been added. You can find it now. For passing clinical exam, at least 6 to 8 months preparation is needed. You can still admit into the course, Dr. Deshan. Yesterday's class recording will be added tonight. Okay. The other books which is added in the Google Drive, it's not must. Okay, so only thing you can, these are just to keep in your hand, but we don't normally need these files. And Dr. Govinda, the online mock test is it's just a mini mock test. We don't take the 16 station mock test in the course. 16 station mock test is usually taken for very small number of candidates, which is like it's excluded from the course. Okay. All right, guys. So that's it for tonight. I hope you're enjoying the session. You are learning what you need to learn. But the thing is that don't feel confused because it is just the start of your preparation. And you will take at least 1 to 2 months just to get along with the course or your preparation. And at some point, it will become much easier. And if you follow what we are doing, if you do the hard work, this exam can be passed without any difficulty. So don't be scared. Okay. And a lot of people will try to demotivate you, saying that it's impossible to pass clinical exam. It is not like that. And for most of you, if you are not going into a work-based assessment like WBA, you have to pass clinical exam to get your general registration. So there is no way other around. So it's better to pass it as soon as possible so that you can just focus on your hospital or on your work job. Okay. Thank you all. Have a good night. Take care.